All right, I'm gonna go ahead and get started. We're gonna start into chapter 8. What'd you guys think about the test? Did you find some of them? Did you feel like it was relatively fair? Like I say, when I see the scores, if I see certain ones that have been missed by like everybody, then I'll take that into account. I'm pretty good about bumping y'all a few points here and there. So don't fret if you didn't, if you were like, oh no, I don't think I did as well as I wanted to. And you may not have, but you'll have an idea on test 2, kind of the way the questions are going to look and the type information. It's going to be pretty similar. However, you're getting to, even if your grades on these tests are not exactly what you want, remember you have all these little sections of this year-long or semester-long thing. If you get most of the points on those, they're going to make up for a test or two. So you'll be okay. Let me share the screen and get it on the PowerPoint. And we'll talk about financial management. Obviously, since we're talking about management roles here, if you are in a managerial position, you are going to be in a position where you are most likely at some point going to have to deal with a good bit of finances, and the way you handle finances can matter to your boss. If they see you spending more than you should, if they see you being a super thrifty type spender, they're going to like that, obviously. As long as you don't have money missing and things like that, that's one of the most important things. So, but we'll talk about financial management in this chapter as far as managerial side of things. So one thing that we have to talk about if we're going to talk about finances in TR management is healthcare costs. So obviously, as we all know, the cost of healthcare to clients in general is rising in North America. So is the cost of most anything else that you can think of right this second. So that's not surprising, and it's been rising for a long time. Now, with a few exceptions, monoclonal antibodies, I think you can get those for free right now. The vaccines are free and things like that they're really trying to contain the pandemic with are free. But the cost of health care per client is rising in North America. And part of the reason, there's several reasons that contribute to this. The aging population, we talked about how we're getting more and more elderly in the population. Increased use of technology. Our computer is more expensive than file folders. Yep. People have to be specifically trained in how to use those things. So it's all the way down, trickles down to like how information is saved. Technology use is going to play into it. Increasing administrative costs. So the administrators are getting more money. Oh, right on time. Catastrophic and pandemic diseases. That plays a role. And then redesign systems focusing on prevention and rehabilitation through outpatient and home health. So when you are redesigning system, you have to spend money and resources to redesign something. It doesn't just happen like that. So money is spent there also. Something else is, if you think about our country, something else that plays into rising healthcare costs is that we really have a low number of, or a pretty good number of uninsured in our country. That plays a role because these, some of the ones that are uninsured, if they have a catastrophic event, you think that the provider is going to receive all the money that they are owed? Probably not, right? I mean, most people rely on a bulk payment from insurance if they're ever going to pay something major off, say a heart attack or something, you know, cancer or something that's going to be long term with a lot of care. Without insurance, the bills usually don't all get paid. So that if that's happening, what's the hospital or the provider going to want to do if they know they're not going to get the money from this person? They start that plays into rising costs. Another thing that I thought of that plays into it also is lawsuits. You know, this society these days is a little bit lawsuit happy, you know, a little more so than I would like to see. But, you know, it's just a fact of the matter. You can drop your test right there when you get a chance on the way by. Or you can come back and do it if you like. Yeah, get comfy, settle in. We're only one slide in. You're doing pretty good. So anyway, I think that plays a role also. I would think that y'all could agree with that lawsuits that's something else, because our lawsuits are people suing for medical malpractice and things. Are they looking for $50,000? No, they're looking for like $5 million, you know, so you're talking big money lawsuits. That plays into the role too. So there's been a change in how people in the US paid for their healthcare in general. And third-party payers assumed client costs, paying all expenses or fee for service. Now we're talking about like Medicare and Medicaid and insurance, you know, Blue Cross, Blue Shield, and some of these situations. That's where those are third-party payers. You know, someone other than the person receiving services. That's a third-party payer. In the 1960s, government used cost-based retrospective payment system and paid following the services. So it was all about what are you getting? Payment came at the end. You knew up front what your cost was going to be. There was a transparency there that I think I would love to see come back, because when you go to the doctor now, you don't really know how much your bill is going to be, do you? They don't tell you this is going to cost this and this is going to cost it. They don't itemize stuff like that. So back then it used to actually be kind of transparent and itemized like that, which I think was a positive thing. You paid after your services are done. What's the problem with that? What if you don't have the money to pay? Back then, you probably just didn't get things done. You know, during the 70s, managed care came into being, and that helped to drive down costs, which was a bonus. You know, we wanted to see this happen. The 80s, prospective payment systems paid based on predetermined rates. Again, you had rates up front. They were predetermined. This is how much you get per treatment for physical therapy on an ankle. You know, if you use the STEM machine, if you use ultrasound, we're going to pay X amount of money. You know, so there that is again with the, you know, the transparent pricing and things. Then we saw 21st century legislation come into play. And what it did was it introduced reforms to improve access and contain costs, pay for performance or value-driven models, which I think is good, because what this does, it's a big positive. It gives, do you want to just go to any doctor for a knee replacement, or do you want to go to the one that's the best in your area? You know, that's something you're going to live with for a long time, hopefully. You want to be able to choose. So it's going to, you know, pay for performance is kind of important there. The better job you do, you know, as a recreation therapist, let's think recreation therapy. The better job you do, the better your performance, the better your pay is. And I think that that's motivating, and I think that that's positive. And that's not saying that is unfortunately based in large degree on like numbers. How many people did you serve? How many hours or quarter hours of service did you put out? And your payment is based on that. How many goals were met? It might have been, you might be paid based on things like that also. So it's value driven. Now, looking at that, just as a comparison, let's think about the Canadian payment system. Y'all know what healthcare system Canada uses? It's a little different than the US. It's a national single payer system administered by the government. So it is universal health care, basically. If you hear the word universal health care, that's what you're going to get in Canada. When you get a chance, y'all can throw tests there, either on the way out even. But just don't forget to drop them there before you leave now. So anyway, the Canadian payment system is different. It's administered by the government. It's funded through provincial and federal taxes. What do you think that does to the taxes in Canada? Think they're low? No, they got to make it up somewhere, right? Let's see. In the 1960s in Canada, universal health care plan through provincial federal cost sharing Medicare is what they used. In the 80s, there was a Canadian Health Act, and what it was about, it ensured that no point of contact fees for medically necessary services. So if somebody needed a service, regardless of what it is, you didn't have to pay at the point of contact at the time of service. Like you didn't have to come in there and do a copay like you do when you go to the doctor now, or pay for your whole visit at the end of your service if uninsured or whatever the case is. 21st century, there's concern for increasing this provincial cost and disparities in access and quality. So what they're saying is, depending on, y'all know that Canada is a huge expanse, right? I mean, it's not some small little country. Where you are in Canada has a big role in what sort of healthcare you're going to get. Are you going to get the best doctors? Certain doctors are in certain areas. The quality of healthcare is it's going to be better for certain things in certain areas. There's specialists, and we all know that there's some doctors that are just the best, right? And they can only be in one place. You've got universal health care. What are some other drawbacks with, and it's something that has been kind of thrown around in this country, y'all. I mean, it's been brought up. What are some drawbacks of universal health care, you think? It sounds all good and gravy when I talk about you go, you don't have to pay, you just show up and then you get your services. What's wrong with it?
Either not gonna get good health care or somebody's got to pay for it.
Yep, it raises your taxes for one. They're really being stressed by what we talked about, the aging population, because they have an aging population too. Costs are increasing, which is going to fall back on the people, just like you said. Somebody has to pay for it. You may not have to go pay for it. You may not have to go pay for it when you walk in the door or when you get your services, but like she just said, somebody's going to pay for it. So money is going to come out. Now, you know where the money goes in Canada for medical costs? Medicines. It's not covered under this. That's where they can make up some of the gap, because you have a gap there. They can make it up on their medicine costs. Something else with this type of healthcare, you don't really get a choice. You don't have a choice of doctor. This is who you get. This is when you can come. A lot of times, say you have especially an elective procedure, say like a knee replacement, something that's not life threatening. It's not going to kill you tomorrow. you might have to wait a long time to get that done under this type of healthcare. Because it's run differently. You don't have choice. You can't go to all these different places. There's fewer providers and there's only certain ones in the area. So there's only so many people they can see and so many surgeries they can do. So the wait times become insane sometimes. And it even becomes an issue in cases of life-threatening situations. You know, people have a hard time seeing doctors in a timely manner, even in some of those cases. So just, I don't know why in the book, they chose to, I guess we just have such a different types of health systems. They talk a lot about Canada, you know, and here we are in the US, but it's looking at the two in contrast to each other. So when you're looking at the two different, you've got, as far as funding in the US, you've got a mix of public and private system administered by the federal government. So there is some federal government entities in play. You also have private, for-profit, and public managed healthcare. Private and public regulations, and doctors are for-profit and not for-profit. You know, you have like specialty clinics, or if you make a, you know, if you're a doctor and you open up a clinic, do you want to make money? Yeah, and you can do that here. That's the thing. You can, now some facilities are nonprofit facilities and the doctors work there. They're still going to get paid, but it's a nonprofit facility. Like if you're talking about a VA, if you're talking about St. Jude, that's not a, you know, Le Bonheur. Some of these places, they're not there for profit. It's different type things. Also for funding, non-physician hospital, partially covered and accessible through health insurance. So if you have treatment at a hospital that's not including a physician, sometimes the hospital will partially cover costs. Your health insurance will partially cover costs, and that's what you usually see. And as we all know, there's wide varieties in how good your insurance can be. Some people my dad had a heart attack and he had to have a bypass, and I think he had like 5 heart stents put in one time. I think he owed $73 at the end. He had good insurance. You know, my deductible would have been way more than that. You know what I'm saying? Like there's a big difference in what you're going to do, and it depends on which one you have. As far as Canadian funding, again, it's a national single payer system administered by the provincial government. Now, what that is when I say provincial, that's like we have the different provinces instead of states. That's all it is. So remember, you know, you got like, what are some of the provinces in Canada? Like Quebec and Ontario and Ottawa and all, aren't those the provinces? So they have governments in the provinces that administer healthcare and the funding. So it's funded through government is all you need to know about that. Hospitals and doctors are privately run, publicly funded, regulated, and not for profit. There's a difference there. You know, they're not. So what will the doctors there be trying to be the absolute best because they can make more money because they can get more patients? Probably not. Same thing with recreation therapists. You know, you don't have the push to strive to be like the best because you're just going to be one of all and you all get the same. So that's what I think is better about the US is that if you're better, you can get paid more. Period. That's what it comes down to. And then what's not covered by your normal stuff can be out of pocket or private insurance in Canada. That's kind of confusing in parts, but it's not as bad as it seems. So managed care and HMOs, these are all about containing costs. Okay, and the book talks a lot about this. There's just two methods that we have on here that are used to help keep medical costs down as a provider, which is what you're gonna be. An MCO, managed care, it's a variety of healthcare plans designed to contain costs using gatekeepers, capitalization, and utilization review. I'm gonna let you look those things up in the book. HMO, Health Maintenance Organization, that's a corporate body funded by insurance premiums, professional practice within geographic and financial limits, serving enrollees or members. So it's like if you work at a specific job, they can get deals, basically, is what this one is about. Or groups can come, you like all recreation therapists get a discount on this because you're a recreation therapist. It's an HNO, a health maintenance organization. What it does is it sets up financial limits where you can, like the most you can pay is this. It keeps you from getting just blown out of the water by something extraordinary that you're not looking for. So we talked about on the last one, managed care plans. Exclusive provider organization, the client pays all of the out-of-pocket expenses outside of the HMO, which is the health maintenance organization. Okay, that was the second part on the prior one. This particular portion of this chapter is a little convoluted and hard to understand part of it. I think you've all probably heard of a PPO, preferred provider organization. This is how managed care plans help keep costs down. And what happens there when you have preferred providers, and that's what I've been faced with this before with insurance. They have certain, what do they call it? In the system or whatever, certain ones that you can choose from. You basically, if you go to an out of system choice, you pay more. Your insurance covers less. If you choose to go out of the, I can't think of this particular word that they use. But for a PPO, you have preferred providers. It's a contract to pay a group of enrollees at a discount paying fee for service when they use these specific providers. That's one way to keep down prices. Okay, you go to a certain group. So what that does for the providers is they have a guaranteed kind of flow of patients because they have a group that is bought in to get lowered rates. So you're going to have more patients and they're going to pay a little less. POS, that's not the normal, that's not what you think. POS, point of service. You combine the HMO and the PPO, the client pays a higher out of network cost, like a network. That's the word I was looking for, y'all, when I said when out of network. They pay a higher out of network cost, but they can select a provider out of the network. They have that choice. With a PPO, they don't have really even have the choice to do so. Okay, that's the difference there. Active treatment. This is something big in recreation that we've talked about. It's a huge concept. It's one of the main focal points when people come in to see if you're doing what you're supposed to do. Surveyors, the watchdogs, I've told y'all to look at this in your plans that y'all are putting together. Who's going to come in and make sure you're doing what you're supposed to do, right? One of the main things that these surveyors are the people that are going to come in to make sure you're following protocols. They're going to look for active treatment, not just from you, but from anywhere at any facility. If you're treating patients, especially patients with developmental disabilities, kids. Now, if you're talking about adults with amputations or something like that, they're not going to care that you're constantly engaging them because they're adults and they don't necessarily need that. But for somebody with developmental disabilities or something of the sort, you need to provide active treatment, which is a consistent you know, you're giving them attention. You're not letting someone who has autism, you know, stand and stare at the clock for 45 minutes. You don't just let them do that, even though they enjoy what they're doing. If the surveyors see you just leaving them alone, letting them watch the clock or do this for 30 minutes, because some of them will, because that's just sensory stimulatory behavior for them. They just, if they see you letting them do that, you're not providing active treatment. You know, you see something like that, you need to say, hey, come on, let's go play. Let's go do this. And then you get them actively involved. You redirect them from what they're doing. That's the point of active treatment. So what active treatment is about, is according to the slide, provided under an individualized, that's one of our key words we all talk about, right? And I said that on a lot of y'all when I turned back your first assignment. One of the suggestions that I gave everybody is to bulk up your info, make sure that you stress individualized, because that's a big thing in therapeutic rec, right? It's not one size fits all. It's not, you know, everyone with autism, this is your, here's what you get. You can't do that. It's individualized per person, okay? It's also goal directed. So provided active treatment is provided under an individualized goal directed treatment or diagnostic plan, which means that it's diagnosis related. Now this is, hang with me, this is financial based. It sounds like we're off topic on this, but it's tied in, because the diagnosis is what allows billing to happen, okay? Someone has a specific diagnosis, therefore they need the treatment because they have the diagnosis. Without that, then what's the justification for them having treatment done, okay? Active treatment is reasonably expected and it's necessary to improve the patient's condition. So what you're doing is, it makes sense and it's going to help improve your patient. That's active. You're actively working with them to improve their condition. That's what it boils down to. And it is ordered and supervised and evaluated by a physician. So somewhere up the chain, it's going to be evaluated to make sure that, you know, hey, we're seeing, and that's part of what is helping TR move forward right now, is that a lot of physicians who didn't before, they hadn't been exposed to therapeutic rec. Now they're evaluating the work of people who are doing TR and they're saying, hey, this is actually working. You know, these people are getting better. They're more mobile. They're happier. They're enjoying, you know, like they're seeing these benefits, and it's making TR be more accepted and more on level with the other therapies, which is a good thing. So this is kind of important and semi-easy to try to kind of remember. Active treatment, the recreation therapist must look to restore, which is get them back to where they were. Rehabilitate, same thing, you know, if that, you think of that in form of like injury when you're rehabbing. Remediate, you're making it more manageable. Or reduce, you know, if it is bad behavior, if it is depression, certain things we want to increase, certain things we want to decrease. So it's, you might be needing to reduce. Or one that doesn't fit in here, it starts with an E, unlike the others, eliminate signs and symptoms of the admitting diagnosis. So this follows like the medical plan of treatment right here. You know, there's different groupings of, you know, thought processes that we talked about in TR. There's, you know, like the medical plan, and then there's like the leisure education model. There you go. This is like medical model thought process right here. They come in with signs and symptoms. This is their diagnosis. This is what we need to work on with active treatment. And that we're either looking to restore, rehabilitate it, remediate it, reduce it, or eliminate the signs and symptoms of why they're there. Okay, makes sense. All right, now we haven't really talked about this before, and I've never even actually done this because I never owned my own place or did my own billing. You know, I always was just paid by a facility where I worked. But service units are broken down for billing purposes. This is pretty important. Service units are a unit of service. Hourly rate is broken down into 15-minute intervals. So remember that. That's you know, pretty good bit, you know, of breaking down an hour, 15-minute intervals. And there's different codes, current procedural terminology, CPT codes. And what it is, there's an annual, yearly, there's a rate setting for interventions by the American Medical Association. So like they say, this is what you get per hour for this treatment. You know, recreation therapy gets blank per hour for active recreation therapy treatment. Now, it's probably not breaking down exactly what you're going to do. You're not, bless you, bless you. She's sneezing her mask right off back there. You don't get a different rate for, say, equine therapy than you would for doing a music therapy activity. If they're both active therapy, recreation therapy activities, there's a given rate by AMA, the American Medical Association, that it has a CPT code. If you're following the procedures that you're supposed to be doing, that's how you know how much someone, a recreation therapist, has earned your facility, by seeing what their productivity is. What is the number of units they produce per day? So what is that? How many 15 minutes did they work in a day? And that's how billing is done. That's what a unit is, 15 minutes. So when we are in recreation therapy, something else, let me go back just because I really think it needs to go on here. It goes with this thing. We've talked about API and what is it turned into now? API, duh. Okay, documentation, billing. If you're going to bill something, think you better document it. If you didn't document it, you can't bill for it. Your facility can't get paid for it. So if you're not doing a good job of documentation, you think the people above you are going to like you? Not very much, because what are they going to be doing? They're going to be losing money because of your lack of documentation. So this is just a reminder to document everything. And there's, you know, there's specific codes. There's not just like one code for everything. There's specific codes in this CPT that's on that slide right there that are used for treatment and for reimbursement. Page 118 and 119 in the book has some, that's where the information is for this, if you want to make some kind of little note there. So there's revenue sources in that you can get in recreation. Some are appropriations, basically where someone basically, this is how much money you get. Like the city appropriates X amount of money for the park and recreation management system. Your facility appropriates this much money for recreation therapy. It's like the portion that you are budgeted, that's what you are appropriated. Contributions. There's people here at Ole Miss that spend all day calling people looking for contributions. You know, for the sports teams, to support the pharmacy department. You know, hey, I know that you're a proud alumni, and I know that you'd love to support Ole Miss by giving us a donation. How much can I get you to send us per month? You know, you've got that going on. You've got contributions. You've also got grants. One of these days, some of you guys will have to work on grants. Grants are important. Grants are tedious. Grants are not impossible, and grants are a good way to get money for specific things. You have to have something in mind. You have to say when you're trying to get a grant, this is what I'm going to do. This is why I deserve the money. This is what I'm gonna do with the money. And then at the end, you have to tell them whether or not it worked. Basically, that's your part of what you have to do with grants. Fees and charges are another way that you can get revenue sources. You know, when I was over the city pool, it cost $3 to come in and swim in the pool per person. You know, you had to pay a fee on the way in. It's a fee for service. And if they came to get, if they wanted to rent a locker, they had to give me a $10 bill and I'd give them a key. And when they brought me my key back, I'd hand them their $10 bill back. You know, so that was kind of like a charge because a lot of people didn't give it back to me and I just had $10 that went into the drawer, not my pocket. I saw some of those looks right there. And then coverage, which would be like insurance, things like that. Budgeting. We've talked a little bit about this, and this is a portion that's in your semester-long project. So take note on this. And this is very, very true. Now, especially the initial time. The first time you do a budget, you're going to hate it, y'all. I'm just telling you, it's like an Excel spreadsheet. Now, hopefully, you step into a place where someone has been there before you and has done a budget, and you kind of get their old budget, and you're like, oh, okay, yeah, close. I want to add a little, and you can almost use their thing, just tweak the numbers a little bit. Because once you build a budget, unless you have a change in facilities, equipment, location, staff, you know, some big change, your budget's going to be really close. You look every year to say, okay, this is as far as like pool chemicals. How much did I spend last year? Do I think I'm going to need more next year or less next year? And you tweak your number up or down according to what you spent each year. And that's same thing goes with rec therapy, you know, arts and crafts supplies, travel expenses, you know, whatever, office items, all these things, you'll have a budget, and it takes 3 to 6 months or longer to prepare a proper budget the first time. Note that it won't take that the second time, but the first time it will take you a while. If you're really looking at doing a thorough full budget, it takes a long time. So, and the steps, and this will be different at different places. It's not the same every single place, but generally you develop a proposal. This is what I propose our budget to be. This is how much I expect us to spend. This is what I propose. You present it to your organization, and then you can get approval from the executive level. Then once it's approved there, you got to get approved by a governing board, which is going to result either in a budget or a legal financial plan. And then it's done by fiscal year, because that's something to note too. Most times fiscal year and calendar year don't coincide at facilities, which is really dumb to me. I don't really understand it, but it's true. It's usually like July 1st through June 30th or something like that at a lot of places. Why that's the fiscal year and why it's not just a calendar year, I have no idea. But that's how your budget is implemented by the fiscal year. So then you evaluate, like I said, evaluation or auditing for variances. That's basically how close did we guess? If you come into a place that's never had a recreation therapy budget and you do a budget the first year and you're a little bit off, should your boss be really mad at you? Not really. They should give you a couple years, a couple of budgets to get yourself straight and get yourself close. Then at that point, you should be pretty close. Now, you can't be going way over and costing the place money, or you'll get in trouble. But you get my point. You know, they have to give you a little bit of leeway on certain things. There's type of budgets, operating or revenue and expense, and that's talking about day-to-day revenue and expenses per year. Like, what do you use for day-to-day operating things that you have to do? Vehicle maintenance, upkeep, things like that. That's what you're talking about. Personnel, that's pay. basically, what are you gonna have to pay people that work there and for you? That's this is the largest component generally in a recreation therapy budget, I would expect for you. If you have any size at all in your facility as far as recreation therapists, it's going to be the largest amount because of the labor intensive nature of therapeutic rec, and it has to be, it's a person centered profession. So there you have to spend time with the patients. So you're going to have, and we talked about in 262, the intro class, how you have, depending on which type of group you're working with, if it's a, like developmental disabilities, you have to have way more staff than you do for the general population, like to do a camp. If you're going to do a camp for quote regular kids and a camp for autistic kids with autism, you got to have like 4 times more staff at the camp for the disabilities. So you have to look at things like that in your budget. So personnel matters. Capital, when you're talking about a budget, like capital expenditures, what you're talking about there, it's long-term, large spending. Things like for the park commission, if they want to build a new pool, it's going to cost them probably $1 million or more. That's a capital expense. That's a big deal. Purchasing land or property, that's a capital expense. Those are big scale items that you're looking to do. If large equipment, something that's going to cost a bunch of money, that's capital. You need to know that much.
How do you want us to set up our budgeting? Like, I know we'll talk about it in the future, but just with it focused right now, do you want us to label in our budgeting, like what's capital and what's operation and personal?
It doesn't have to be broken down into that. Just get it on use an Excel type sheet, a spreadsheet to do your budget. And it would, that would be a good way to do a budget anyway, honestly. You may not have, depending on your place, you may not have a capital expense on hand, it would be kind of good practice to add something like that. We hope to add 40 more acres to our facility, that would be capital. But yes, it could be broken down like that. And then but it doesn't necessarily have to. Just use a spreadsheet, break it down where it's easy to read, and it's going to be a guesstimate for you. You can have make it a educated guess, on your budgeting. I'm not going to go through and check prices for all your everything you say, and I'm just going to kind of go with it if it makes sense and looks like a real budget. There's different types of budget formats. Incremental is one, and that basically is a line item budget, which is what I've done and what you'll probably use at most places. There's one item on each line. You use a spreadsheet and it shows and justifies yearly changes. That's what incremental budget is. Zero based. That's where you have to show justification for each expense every year as though it's never happened. A little harder. You have to justify everything each year. That's the difference. It's starting from scratch every year. Zero based. You're starting from zip. Incremental is better. It's line item. You can look at last year's budget, this year's budget, and what is the change going to be? What did we say we were going to spend? How much did we? That's a good thing about incremental. Program, that budget, each specific program is budgeted separately. Like if you have recreation therapy and you have animals, or like an equine therapy, and you have horticulture where you have plants and things like that. If you have movement therapy, a pool staff, each one of those would have a separate budget. Okay. That's what each program would have their own different budget. and you look at things like our, oh, that's it for that. Performance budget is the next one. And you look at things like what they're looking for here is strictly like you're looking for performance. Is there justification for funds? Are they doing a good enough job per program to get their funds? Are the outcomes meeting the goals? It's a cost efficient way to do budgeting, but it's time consuming. It focuses on outcomes and results. And one good thing about this performance budget is that it leads to increase in production, because it's based on what I said, meeting goals, and justifying funds. If you're not doing a good job, are you going to get the funds that you need to do what you need to do? No. So that makes the productivity rise. Desired quality levels and outcome measures are there to see if goals are being met. That's part of that. And then a flexible budget, you calculate costs based on changing volumes, like client volume. If you work at your budget might change a lot depending on the time of year in your facility and depending on how many patients you have. If there's a big change, your budget needs to be flexible. If there's certain times of the year where, say you're a sport rehabilitation facility that uses recreation therapy. Okay. There's certain seasons for different sports, and certain sports where you have more injuries. Let's just say football. So you're probably going to see more patients during, from when? Say August through, that's going to be a hot spot for you. So that flexible schedule could work in that situation, because it's not going to be where you need X amount of money per month, because some months you won't need as many staff because you have changing numbers of clients. Does that make sense on the flexible one? I know this is kind of a lot of info and kind of flat, but you do need to know these different budget formats. So this is a pretty good slide show, though, as far as when you go to take the test. And if you halfway paid attention to the last little part where I explained those budget formats, that'll come in handy too. If you didn't turn in your test, turn it in on the way out. Next class, we'll probably go ahead and knock out another chapter. We'll talk about staffing services, chapter 9, on Thursday. Y'all have a good rest of your day. Stay safe. Don't get sick.